you like that? Anyone recognise it? No. The Dark Island. It's now regarded as a traditional Hebridean song, but it only dates from the 1960s. It was the signature tune for a BBC spy thriller called The Dark Island, and it was filmed on Benbecula and is now indelibly associated with that beautiful outer Hebridean island. So I offer you a small picture of wildlife, just to change the atmosphere slightly. I thought I'd spare you the pleasure of hearing the other version that my iPad has on it, which is it being played on the bagpipes. So, working patiently. If you've read the programme, and thank you, Julie, for the introduction, you'll know that I've spent a lot of time working as a patient representative and sometimes active advocate in and around cancer research and the NHS. So to start with, I thought you'd like to see why I qualify as a patient. Although I don't have a bone sarcoma, it's a soft tissue sarcoma. And I'd be happy to talk about that later if anyone wants to know more about similarities or differences. Like many other people, I had the feeling of needing to do something positive on the back of my initial sarcoma experience. By background, I'm a journalist and television producer, so I had some of the skills that were needed, including perhaps a stubbornness, which means I rarely see no as a valid answer. I'm now experiencing that in the wake of grandchildren. Of course, this all begs the question, why should we get involved in the first place in the running of the health service? Why don't we just leave it to the professionals? Well, I think that's a question that belongs in history. It started to be answered by the professionals in 1995. We can see the roots of the reform of cancer treatment in the Kalman Hein report, written by the chief medical officers of England and Wales in 1995. It's a very brief report, only about 30 pages, including appendices. But it starts to map out a new approach to treating cancer in the NHS and indicates some of the structures that then started to be put in place when the new government gave cancer priorities in 1997. Professor Sir Mike Richards, until recently National Cancer Director, was closely involved in the Kalman Hein report. And so was Professor Peter Selby, one of the founders of the National Cancer Research Network. Kalman Hein made it quite clear, and the quote is on the screen, that patients had an important role to play in change and in ongoing improvement. The Cancer Plan, first published in 2000, was also a very short document, but a very influential step. It encouraged many enlightened oncology practitioners to bring patients into decision-making processes. It's probably fair to say that the first steps to involve patients were taken in research. In 1997, an organisation known as UKCCR coordinated cancer research, bringing together the charities, government funding, etc. In 1997, it brought patients into its clinical studies groups for the first time. These studies groups were taken over by the newly formed National Cancer Research Institute, the NCRI, who continued to expand that involvement by bringing patients into the national management structures and the strategic decision-making of cancer clinical research. When Leeds University was chosen by the government to run the National Cancer Research Network, there was a patient on the selection panel. I joined the NCRI Sarcoma Clinical Studies Group in 2002. And at that time, there were 13 patients involved with NCRI and NCRN. And that is after 5 years of active recruitment. Together we established the Consumer Liaison Group to provide a coordinated patient voice between us, to be a focus for training, and to bring together the patient resource so that it could support the development of research. The Consumer Liaison Group today has about 50 core members who work on the NCRI clinical studies groups. The Sarcoma Group has 2 carers, in fact, working on it, and I'm still on it as a patient. There are probably as many past members of the Consumer Liaison Group who have served on the clinical studies groups, but who continue to work with NCRI and NCRN on a variety of roles in the research infrastructure. Many of these people, and I'm one of them, have also played a part, or are still playing a part, in the way the cancer services are developed and are developing. For example, the National Cancer Patient Experiences Survey, which goes out every 2 years and seeks 70,000 patients to give feedback about their experience. This survey has patients sitting on its steering group. They have a major influence over the way that the questionnaire is designed, drafted, tested, and in the way that the results are analysed. Another example is peer review. This is a process which assesses the performance of specialist treatment teams. It includes patients on the review panels. And the power of this process is such that multidisciplinary teams must be up to standard, or they can be closed down. And this is not an idle threat. One sarcoma specialist centre, is currently being closed down because it cannot meet the necessary standards. It will no longer undertake surgery. It will be reduced to being a local provider of chemotherapy and radiotherapy and a support locally for diagnosis. So that's a powerful way for patients to be involved. And in fact, peer review is at this very moment looking for additional people to be involved. For my part, I spent 5 years as a member of the advisory board which supported the National Cancer Director and his National Cancer Action team. This panel was made up of clinicians, representatives of the Royal Colleges, representatives of the cancer networks, and the major cancer hospitals, such as the Christie and the Marsden. And it was chaired by the Chief Exec of Cancer Research UK. This advisory board got to contribute ideas and discuss change, monitor how new developments were being turned into practice in the NHS, and could give broader-based comment in response to the way things were developing and evolving. It was important that I did not just respond as a sarcoma patient, but as a patient more generally. My bias towards rarer cancers was understood by that group and expected, and I can remember occasions when that voice was needed. Other patients in the group, not unexpectedly, represented more common cancers, but they came and went. I was the only rarer cancer representative in that group for 5 years. No one else seemed to be available. My own involvement at this level finished in 2012, although I remain, as I said, a member of the NCRI Sarcoma Clinical Studies Group, until next year at least. What I thought I'd do next is have a look at some of the projects I've been involved with to try and give you an idea of where and how, in a bit more detail, patients can work with the professionals and hopefully add value to the system. When you start doing something like this, it's a bit like climbing a ladder without knowing quite where you're heading. You may recall some years ago stories about how patients were being denied access to high-cost drugs because NICE had refused to accept them yet, but clinicians still wanted to use them. Mifepristone, Mepact, was one of them. Patients were funding treatments themselves, and then newspapers reported that different hospitals took different approaches to how that was allowed to happen. Some patients being financially penalised by their local hospital. The Secretary of State asked Mike Richards to review the situation and recommend a standard approach. I was part of this consultation. The stance I took was that hospitals should administer any licensed drugs as long as the patient's doctor wanted to prescribe them, even if those drugs had to be acquired elsewhere. At least that approach, I felt, would ensure equality. We won the argument, despite doubts from many doctors, some active resistance from hospital administrators, and quite a few comments that we were actually threatening the integrity of the NHS, which I find a bit ironical given what's happening in the last 3 or 4 years. In 2005, the NCRI planned a 5-year funding programme of research into palliative and supportive care. The aim was to fund 2 collaboratives, each bringing together a number of research groups at different universities. Our patient group in NCRI was keen that one of the 2 collaborations should be focused on psychological and supportive clinical issues, rather than both collaborations being purely medical. We won that argument, and I had the great fun of working with the SECO collaborative, which took on that palliative and supportive research role, the psychosocial role, for 5 years, working with Southampton, Lancaster, Nottingham, Manchester and Liverpool universities. And I believe we made some really valuable contributions during that programme. There's a growing movement in Europe, which I support, to see better integration between oncology and palliative care. The belief being that better patient decision-making will come from better knowledge, especially if we can get more complete information about what palliative care actually means. It is not exclusively end-of-life care. Technically, I've been in palliative care for 15 years, but end of life is still a fair distance away, I hope. A recent clinical study in lung cancer showed that patients receiving proactive palliative care can live longer and with a higher quality of life than those receiving aggressive, so-called curative treatment. There are lots of lessons out there waiting to be learned, and we need research badly to help us understand it better. And this is research which the pharmaceutical industry will not help to fund. One of my great pleasures was to chair the National Prevention Research Initiative for 3 years. This was run by the Medical Research Council, and in my time we invested £23 million in original research into the causes behind chronic illness, including cancer. We had a strong cohort of patients involved in the initiative, and many of the studies we funded included patients as active participant researchers within them. Another initiative which took on that patient as researcher theme was the National Cancer Survivorship Initiative. This started in 2008, and I led one of the work streams for its first 2 years. The issue we looked at was the fact that every cancer patient is a survivor. It's just that some of us survive longer than some others. What then does this mean for the provision of better care and access to further treatment when it is needed, whether that's for the management of side effects or earlier treatment for a suspected recurrence? The initiative together brought up the concept that every patient should have his or her own care plan. And when discharged from active treatment, they should be part of the development of that care plan, aware of what is in that plan, and have a copy of it for themselves. This is now starting to be implemented, and hopefully in the next 2 to 3 years, we'll start to see such plans being put in the hands of our patients and helping get over some, I hope, of the concerns that were expressed in Andrew's session downstairs a little earlier. Research involves patients everywhere today, at local and national levels. There are patients appointed to the board of the National Cancer Research Institute. Government sits on that board. Direct access to patients in the context of research. The National Institute for Health Research has patients at every level of activity within it, from board level down to individual programs and individual projects. But it's still difficult to evaluate the effect of having patients involved because the interactions with professionals can be a bit subtle and non-specific. Very hard to put your finger on the fact that a patient changed that particular idea, changed that particular activity. But I know from my own experience that just being in the room changes things. What we believe, and feedback from professional researchers, doctors and scientists confirms it, is that we're developing better clinical studies now than we have ever done before. Studies which are more attractive to patients who are invited to enter them. This means quicker accrual of the necessary numbers of patients, and the results get published more quickly too. Things move on, and new drugs are being developed to do things which were impossible in the days before genetic analysis. And Bassassan's presentation is an absolute perfect picture of that kind of change. The need for new models of clinical research is something that patients in Europe are working on with the professionals. And in sarcoma, as Bass showed, we are starting to use innovative statistical methods, Bayesian statistics. We're starting to have deeply integrated biological studies alongside clinical studies to understand not only the effect of the drug on the body, but the effect on the drug of being put into the body, so that you get a whole picture of what's happening. We're also developing in sarcoma so-called basket studies, where a collection of drugs where there are huge questions about whether they may or may not be effective in sarcoma. But we can use one clinical study to test 6 or 7 different drugs with different sarcomas. And that route forward, when there are so many new agents coming into the pharmacological catalogue, is really a great opportunity for us. Of course, we can't think of new drugs without thinking of NICE. There was a question earlier relevant to MEPACT on that. And I'm sure that many of you here will remember the 3-year fight we had to get MEPACT approved for adjuvant use in osteosarcoma. The drug at that time was controversial, And for one or two scientists and doctors, it still is. Because although we know it works with the immune system and macrophages, no one actually understands how it does it. However, the data from studies very clearly indicate that it does work. Getting NICE to accept that fact and then to recognise that its health economics modelling, which was based on 10 years of survival, was inappropriate for a drug whose main target patient was a teenager, possibly with 30, 40, 50, 60 years of life ahead of them if the drug was successful. That was a battle. I have to say that BCRT bore the brunt of the public face of public involvement, patient involvement in that process, and we all owe a lot to Mike Francis and the three young patients, Sally, Hannah and Kalman, who attended committee meetings with him. They made a very clear impact on the NICE advisory groups. But NICE is much more than drug approvals. There's a lot is embedded now deeply in the NHS. At this moment, we have our 9th drug approval process in sarcoma underway. It looks as though we're going to get this particular drug approved, which is nice. That's not meant to be a pun. We're currently working with NICE on quality standards. We have a debate running with them about a medical device, which we believe creates unacceptable risk for a group of sarcoma patients. And we're trying to persuade them to revisit what is known as the Improving Outcomes Guidance, which was published in 2006 and which changed the structure for the way that sarcoma is treated. We think it needs updating. They want to shelve it and forget it. Another group which has patients working on it is the National Cancer Intelligence Network's reference group for sarcoma. Importantly, NCIN has recognised that the charities should have a voice just as patients do. So both patients and charity representatives are on the sarcoma reference group. NCIN recognises that the charities play an important part in ensuring that information and understanding, which is developed from detailed analysis of cancer registry and hospital data, can be better handled through charities. It's being developed from detailed analysis, all this new information, and we need it to be widespread and accurately understood. Analyses which distort data are quite common in other areas, loved, of course, by the popular press. So it's important for all of us that the cancer information made available publicly is accurate and that the analysis of that data is not biased by hidden agendas or otherwise misrepresented. Just to give you an example, this slide gives an immediate impression of the depth of data now available. I'm sure Jill Lawrence will forgive me for using it out of its original context. It represents the incidence of leiomyosarcoma, a soft tissue sarcoma, by age over 25 years, with the coloured segments identifying the part of the body affected. For Sarcoma UK, this immediately highlighted the pink area, gynecological sarcomas. And today we have a developing campaign which is being built on this data and deeper understanding of it to see how we can improve outcomes for this group of patients whose survival is amongst the poorest in the whole catalogue of sarcoma. These data, just expressed in a simple, colourful chart like that, were really, really powerful in bringing it to our attention. The NHS may never be perfect. There will always be patches to keep it together. But we have got sarcoma patients helping the NHS do what it needs to do in lots of places, and there's going to be plenty of opportunity for many more interactions of this kind. The changes of the last 3 years, which the current government has introduced, have seen things move in some new directions. Not least, we have lost the National Cancer Action Team, which was a great reservoir of knowledge and experience in getting things to happen. I think the government would argue that much that has been learnt in cancer is now being replicated for the benefit of other disease areas. In cancer, however, we seem to have lost some levels of influence, while strangely gaining a stronger voice, perhaps deeper into the system. So, if the opportunity comes up for you to work patiently, please consider it. The sum of what we are all doing is very important, even when, for the individual, it may not feel like you're making much of an impact. I want to leave you with some lessons that I've learnt on my journey. I'd like to help you understand that how we make ourselves heard and our ideas and experiences understood is actually very simple and doesn't require special knowledge or even a perverse stubbornness such as I lay claim to on the odd occasion. So, I hope you can read those. I'm not going to read through them. I'll leave you to read them for yourself. Thank you. Questions?